everyone, welcome to ResearchMD.com. Another great presentation. We are doing a series on electrolytes. Okay, we're going to teach you everything about hyponatremia today, a very important electrolyte abnormality. Again, all our presentation under 9 minutes. The key is repetition. Keep watching the video again and again. My name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency, and I teach medical students and residents on a regular basis. I'm a director of research and I'm an assistant professor of medicine also. So let's get into our topic. Okay, when you talk about hyponatremia, you have to know two more major important things. One, it can cause cerebral edema. It can also cause us like the osmotic demyelination syndrome. So remember that before we even get into anytime you learn about a subject, what is the emergency? Two emergencies: cerebral edema and osmotic demyelination syndrome, which we'll come back to later. So let's look at the definition and start with hyponatremia: serum sodium less than 135. Okay. And then epidemiology, we talk about mainly in hospitalized patients. It's very common. Elderly patient is also, women is also very common. Based on the serum osmolarity, hyponatremia, you can put it into three categories. One is hypotonic hyponatremia, then you got isotonic, and you got hypertonic hyponatremia. Okay, when you talk about hyponatremia, it's the most common cause of hyponatremia. Measured serum osmolarity is less than 280 with a relative excess of water in the extracellular fluid. And when you talk about isotonic hyponatremia with the plasma osmolarity around the normal isotonic, which is 280, 295. When you talk about hypertonic, we got 295 and above. Okay, so remember that classification. You can look at the volume status and you put it. That's another easy way to remember. Is it hypovolemic euvolemic hyponatremia or hypervolemic hyponatremia? The examination question is going to be like, what's the most common cause in the United States? Euvolemic hyponatremia. Always pick SIADH. And how do you treat SIADH? Fluid restriction, my friends. Okay, and based on the serum sodium concentration, we can say mild, moderate, and severe. If it is less than 120, it's become very severe. That's what you need to kind of admit the patient to definitely in the hospital. Risk factors, so many risk factors. Older age, you see all the time elderly patient because of their volume status, female gender, smoking status, kidney disease, increased risk of hyponatremia. Anytime you have diuretic, it's like thiazide, SSRI, and all of this drug can cause oxytocin, increased risk of hospitalization in patient with the CHF, chronic kidney disease, and cirrhosis and pneumonia. The other thing also you need to remember, anytime you admit a patient for any other causes, or like let's they have pneumonia and you find the sodium is low, it's a bad sign. It's one of the worst prognostic indicator also. Symptoms, usually patient present with weakness. You can have nausea, vomiting, confusion, headache, depends on where you can have seizures if it is very severe. And finally, you can have like coma. So we have to be very careful. Okay, symptom of hyponatremia. For acute hyponatremia, like less than 48 hours, you can have cerebral edema. Okay, mild hyponatremia, you can nausea, vomiting, headache, and those kind of thing, and maybe altered mental status. For chronic hyponatremia, neurocognitive deficits can happen. You got confusion, lethargy, dysarthria, gait disturbance. Seizures are very common. It's rare, but if it is the sodium becomes very low, then you can have it. And also remember, like when a patient comes like a fall, like in an elderly patient, what's the most common they present with? The falls, right? Then you can have like make sure you check your electrolyte. They usually have like they can have like sodium and all that. Diagnosis, you measure a couple of things. First, we talk about the volume status, right? You can always look at the volume status of the patient, like looking at the urine analysis, what's the specific gravity, right? You can look at the hemoglobin, like hemoconcentrated. You can look at the vital signs. The heart rate is like tachycardia. You can look at the skin tone. A lot of things you can do, like look at the volume status of the patient, right? Then you should measure the plasma sodium, then you measure the plasma osmolarity, because we have this classification we talked about. You have to look about the serum creatinine, BU creatinine ratio, uric acid level is important. Urine osmolarity you have to do. Urine sodium concentration, and of course fractional excretion of sodium, right? All of those kind of things comes into play. So let's look at some flow diagrams right here. Serum sodium less than 135. You measure the plasma osmolarity, right? And then hypotonic, determine the volume status, check urine osmolarity, and the sport urine sodium, and FeNA you check. And if it is isotonic, you can look at the pseudo-hyponatremia causes, and then look at hypercholesterolemia, and IVIG, and monoclonal gammopathy. So when you talk about, when you talk about like hypercholesterolemia, it's very important when you have triglyceride. I remember I was seeing a patient like a few years ago, where this patient have like severe triglyceride, like maybe in the 10,000, I think, in this patient. And the sodium, they cannot, because the serum was so thick, they couldn't measure the sodium. So the lab measured it as like, really low, which was an error. And patient ended up having hypertonic saline, end up having bad outcome. I think the patient expired in that case. So very important to remember all of that. Hypertonic greater than 290, check glucose. So the next thing we have to do is like determine the volume status, right? You check the urine osmolarity, sport urine sodium, and FeNA. First, if it is hypovolemia, and then urine osmolarity is like less than 50 and FeNA is greater than 1%, you have to think that's a renal sodium loss, okay? If the urine osmolarity is greater than 500, I think it's 500, okay? Urine osmolarity is greater than 500 and the FeNA is less than 1%, you need to think about extra renal sodium loss. Now, when you look at a euvolemia, again, anytime when I say euvolemic hyponatremia, think that's the most common cause is like SIADH, okay? Rule out hypothyroidism, adrenal insufficiency. You look at the urine osmolarity is like greater than 100, then you can say like SIADH and low, and we can talk about SIADH. If the urine osmolarity is like less than 100, then you have to think about primary polydipsia also, okay? Just remember, euvolemia, you look at the urine osmolarity is greater than 100, think about SIADH. If it's less than 100, think about primary polydipsia. Sometimes it's good to know what's the most common cause. Then you come to the hypervolemia. If the urine sodium is less than 20, then you have to think about heart failure, cirrhosis, nephrotic syndrome, okay? If the urine sodium is between 20 to 30, then you have to think about, you can still think about heart failure, nephrotic syndrome, diuretic use. And if the urine sodium is greater than 30, you think about renal failure and diuretic use. So if we use this flow diagram, we can pretty much give you an idea of what is the cause, what causing hyponatremia, okay? So the treatment is like, avoid complications. Don't rapidly correct it. Don't jump into, if the patient is asymptomatic, just be careful. That's what I'm saying. I've seen them all the time. You see the number, you try to treat the number. Always look at the patient first. If you don't have to kind of jump in and give like, hypertonic saline right away. In any numbers you see, like if somebody have like a blood sugar, I see like 800, 900. Unless the patient is not having many symptoms, you can take your time and gradually bring it down. The key is gradually bringing down the sodium level, okay? If you bring it like more than fast enough, you can have like severe complications. So severe symptomatic hyponatremia, rapid increase in the sodium, you want like 4 to 6 mmol requirement. It's like in 24 hours, you may want to consider maybe like 10 to 12 milliequivalent, okay? And then IV infusion, hypertonic saline is recommended, 100 ml over 10 minutes. So that's in the severe circumstance. Patients start having seizures. It's less than sodium is less than 120. So for moderate severe symptomatic hyponatremia, start prompt treatment. Consider stopping all the medication. We talk about diuretic, right? And then hypertonic saline is the treatment available. Rate of correction, you be very careful, right? Anywhere from serum sodium, you can have a usual risk of osmotic demyelination syndrome. That's what we need to worry about when you correct it too fast. Remember, correct it slowly, gradual, okay? Osmotic demyelination syndrome, again, deadliest consequences of like, brain injury resulting from abrupt change in the brain osmolarity. And then you can have like, a patient usually die when you have osmotic demyelination syndrome. Thank you so much for watching. We'll be back with another presentation soon. Thank you.